Hello, and welcome to another episode of the Creating Sunshine podcast. Today is so special for a couple of reasons. Number one, we're in person, and I'm like getting obsessed with being in person. And number two, somebody that's near and dear to my heart that has been here almost this whole past year with me through my breast cancer surgery, my surgeon, Dr. Divya Srinivasa. Welcome to the show.
Thank you so much for having
Of
me.
course.
It
This has been a
feels
long time coming.
I know, I was gonna say it feels really special
Yeah.
because one of the things I always tell patients when they come in is 6 months from now, a year from
hmm
now, it's gonna be a totally different phase of life. Is a light at the end of the
Yep.
tunnel, and it's so nice because we are existing in this moment
Yes.
in your light at the end
Yes.
of that
I'm so
tunnel.
glad that and because I asked you a while ago, but I'm actually really glad that it's ending up at this time
Yeah.
because it is. I'm like 6 months post surgery, and
Mhm.
this is a perfect time, to kind of tell people. I feel like this is going to be such a value packed episode because we're going to talk about your career. We're going to talk about what you do, what people are normally told when they go to see a breast reconstructive surgeon when they're in the thick of it, of breast cancer, and like what the possibilities really are, and how I've navigated that with you, with insurance, with all the things. So I just buckle up, guys, because this is going to be a good one. But I want to start with like you and your career. Did you know you always wanted to be a breast reconstructive surgeon, or like how did that kind of come about?
I knew that I always wanted to be a surgeon from, like, mid-medical school. And I really liked plastic surgery. And actually, the first rotation that I fell in love with was pediatric plastic surgery. So, operating on children, cleft lip, cleft palate. Quickly realized I really loved children, but I didn't like operating on children.
Mm,
And I think just the way I was raised, my mom is one of many, many sisters. Unfortunately, two of my aunts have passed away of breast cancer. And I grew up in a very feminist household. I have two sisters. All three of us are surgeons. And so I think whether I realized it or not, there was a very natural progression towards being a women's health advocate.
hmm
So I think if you pair women's health and women's health advocacy with plastic surgery, you get breast reconstructive surgery.
You know what's so interesting? I didn't know that about you, but my youngest daughter was actually born with a cleft lip and cleft palate.
Yeah?
Yes.
It's incredible surgery. So
Yes.
much love to the
Amazing.
craniofacial surgeons, but I realized I love children
hmm
and I didn't love being a doctor for children.
Mm. So, but to go a little bit further, I want to talk about your credentials, like everything that you have, and how like the drive to just keep going and to get all of the things that you've gotten instead of just I'm going to be a breast reconstructive surgeon. So like share a little bit about what exactly your career path, you're double board certified, all the things.
Yeah.
And you're a mom.
Yes. It was funny. I actually was talking to my microsurgery fellowship director last night, and he's now the division chief of the plastic surgery division at UCSF. And we were catching up, and he was saying, it's so nice to catch up with you and hear all the
Mhm.
great things you're doing. And I said, you know what's funny? We've known each other for a very long time. He's known me since I was an intern, and I didn't match into plastic surgery. Plastic surgery is one of the most competitive matches out of medical school, and I didn't get in to the direct program. So there are a lot of different ways you can become a
Mhm.
plastic surgeon. The most common ways you get directly out of medical school into what's usually between 6 to 8 years program, and that may or may not include some research years. I didn't get into one of those direct programs. The other way that people do it is you do a full general surgery residency, and then you can do additional plastic surgery residency training and beyond. And I just knew that I was going to be a plastic surgeon. So I did this intern year at UCSF, and I did a great job, and I ended up completing general surgery. And I knew all the way through general surgery, and I got married and had a child in general surgery. And I'll never forget my program director at the time. You have to get this paperwork signed basically saying that the program director knows who you are and agrees
Mm.
that you're allowed to apply for fellowship. And I kept bugging him. I was like, are you going to sign it? Are you going to sign it? And he said, why do you want to do this? You're married to somebody. My husband's an interventional radiologist.
Mhm.
He goes, he's already done with training. He does well for himself. Why don't you just stop now? Why do you need to do more training? And I I almost grew up in a delusionally feminist household, right? We
Mhm.
grew up just being told you can be anything. You should always be able to provide for yourself. And I never in my life had anyone question what it is that I wanted to do or tell me that I shouldn't do it or couldn't do it. And it was honestly the first time, really, that I had someone in power who's in charge of my education genuinely act like I was crazy for wanting to do more training. And I said, it's what I want to do. Why is that hard for you to understand? I can be a mother. I can be a wife. That's great. I'm glad that my husband does well for himself. I'm
Yeah.
glad that he's done with training. Great. This is what I want to do, though. So I went on to do plastic surgery training, loved it. And in that, had to make a decision. That's usually already plenty of training for someone to go out and be a cosmetic surgeon or be a plastic surgeon. And you can do breast reconstruction without doing additional microsurgery training.
Mhm.
But I actually really fell in love with being a microsurgeon. I loved this idea that, in cancer, you can't always replace what is lost.
You're right.
But it's pretty close with microsurgery to be able to replace what is lost, to be able to bring natural tissue back to the breast and reconstruct a breast and do it so well that to others, they may not even realize that you had a mastectomy. And that to me was tremendous. And so then
Mhm.
I knew I wanted to do microsurgical training and I wanted to be fellowship trained because it was important to me that I was 360 degrees comprehensively trained to the best of anyone's ability to offer every single option. So there wasn't much conversation about it. I told my husband I wanted to do it. He's a
Mhm.
saint and said, yeah, whatever it is you want to do, we'll support you. And I ended up back at UCSF, back where I started to do my microsurgery training. It was really like a 360
Full
moment for
circle.
me, full circle.
I love that.
And I just never in my life did I ever not do what I felt like I needed to do to be who I want to be.
I love that. And I'm so thankful that you did and you kept going because I mean my results have been amazing and we'll talk about that too. But now you're in private practice. So then what made you decide that you wanted to do private practice versus working for someone else?
Yeah. Not just working for someone else, but really functioning in a very large hospital system
Mhm.
in academia. When you train at very academic centers, it's really easy to believe that you can only do the best job in academia. And I really thought that's where I needed to be to do my best work. So I applied for the academic job in Los Angeles at a really well-known center. I got the job. I was so excited. And I don't regret that time. It gave me an opportunity to really perfect my craft. And when I applied for the job, I was doing all sorts of microsurgery. I did head and neck reconstruction, I did leg reconstruction and breast reconstruction, but it became very obvious very quickly to everybody that I really had a special skill set when it came to breast reconstruction. So
Mhm.
within 6 months, I sort of became the breast reconstruction person. And my colleagues performed it as well, of course, but I was doing the highest volume of it, and it
Mhm.
became a dedicated part of my practice. And because I was doing so much of it, I quickly realized where the deficiencies are.
Yeah.
And we could have a whole podcast episode dedicated to the misogyny, the chauvinism, the difficulties that
Mhm.
I dealt with being the only ethnic female in an otherwise Caucasian male group of surgeons and what that was like for me, because that had a lot to do with why I left as well.
Mm.
But it was also, there was this one moment in clinic, a patient was over 45 minutes late to an appointment. And the clinic, remember, the clinic is there, it's all the surgeons that practice there. It's not
Mhm.
just me. There was sort of a rule if you were more than X number of minutes late, your appointment got canceled. And I explained to the team many, many, many times that rule does not apply to me because patients are not coming in for their facelift appointment or for whatever, for a cosmetic reason. They're coming in for breast cancer reconstruction. It's not really like an optional thing for them.
Right.
If they're late for this appointment, it's because they got held up in lab. It's
Right.
because their oncology appointment ran late or because their other doctor was running late, right? There's a million reasons that
Right.
are not their fault. And chances are 99% of the time, if someone's late to their appointment, it's not because they just were running late.
Right.
There's a reason for it and it's out of their control. Therefore, I will always see that patient. Don't ever cancel an appointment.
Mhm.
And they did anyways, and I was furious.
Mm.
And I called the patient and I apologized profusely. And I said, just out of curiosity, why were you late?
Yeah.
She said, well, I got caught up in lab. My labs were low after chemo and they wanted to recheck. I think it was a white count or
Yeah.
something. Again, not her fault, right?
Mhm.
And now the breast plastic surgeon canceled her appointment. And it was sort of just this moment where I realized I can do what I am doing better if I am in control
Yeah.
of the patient experience, and I didn't have that control in the paradigm I was working in. So I left.
I love it. And I think that it really speaks volumes for my own personal experience with you and with your office because there's so many things that were done differently. Like I can't even get a hold of my primary without leaving a message and calling 3 different numbers and pushing. But, for you, it's like the cell phone numbers are there. Like
Yeah.
that was just I was blown away. People are calling to check on me. I'm texting, I'm sending pictures and I'm like this is phenomenal. You don't feel like a nuisance, you don't feel like a bother. You don't just feel like like a number.
Yeah.
You know what I mean? Like you actually feel
And you never should.
feel the
never
care.
should feel like another number,
Yeah.
but so many patients report that experience.
Yeah.
That's why for me, every patient gets my personal cell phone number.
Mhm.
All of them. Because and it's extremely unusual that a patient would abuse that privilege. It
Right.
really doesn't happen often because
And if we do, you just text us and say, call the office.
Yeah.
Because
Well,
that's
yeah.
happened to me.
Yeah, I just say, hey, this is not something you got to text
Right,
me
right,
about.
right,
Call the
right.
office. But that's okay because the benefit is when it's a weekend or it's
Yeah.
after hours and there is an urgent or emergent issue.
And for me, that's always when something happened.
Yeah.
Sunday night, Friday night.
Right. Text me and call me
Yeah.
and I will let you know. I'll say, hey, yeah, let's take care of this.
Yeah.
Let's figure this out. This is what you need to do with the drain, or can you come into the emergency room, or
Yeah.
let's start you on this medication. And if it's not, I'll say, hey, don't worry about it. I'll have somebody call you on Monday.
Mhm.
But at least you communicated with the
And
physician.
you have that peace of mind because
You
you've
have peace-
talked to the doctor.
Exactly.
Yes.
And peace of mind is so important,
Yeah.
right? And it is 3 seconds out of my day.
Right.
I don't mind. But what I quickly realized is it's not just important for me to have a cell phone. Multiple members of my office have a cell phone.
Yeah.
It's not just a landline. My nurse practitioner has a separate phone for the
Yep.
practice. My back office MA has a separate cell phone. And it allows people to communicate in ways that are so much beyond a landline and a
Yeah.
voicemail, right? We have email, we have text message, we have photos. There's so many ways we can communicate. And it has revolutionized the patient experience, in my
100%.
opinion. And I'll never change it. I'm never going to go back
Yeah.
because it works for both of us. I want to know if something's wrong
Right.
because I want to fix it,
Right.
right? And if nothing's wrong, I don't want you to go through the next 48 hours worrying something's wrong when
Mhm.
I can just tell you nothing's wrong.
Right.
So these are the kind of things that I have control over and I can do
Yeah.
when I'm the boss.
Now that you're working for yourself. Yes. And the other thing too, I think that a lot of people, we talked about this before we hit record, when people hear private practice, they get scared because first thing you're going to do is you're going to call your insurance and they're going to say, she's out of network, she's not approved. Right. And for the people listening, that was the situation with me. I was out of network. But there are so many ways around that. And I wanted you to speak a little bit about you
Yeah.
and your team and how important that is, because it's not just you telling us, well, you have to call insurance. Like your team literally works through step by step. And I even remember when I had called my insurance and I had all of the information and they were like, well, you're not going to have all the information you need. And I was like, well, what do you need? I mean, and I had tax ID numbers, I had CPT codes.
Yeah.
And even the insurance was like, oh my gosh, like they were so impressed.
Yeah.
But to speak to a little bit about the process of somebody that, because you are out of network, but how
I
they
am.
can still
And we can
work
even
with
title this like the out of network episode
Right.
because I just want to rip the Band-Aid off of that controversy. I am an out of network surgeon. It is all over my website. If you try to make an appointment with me, it is the first thing that they will tell you because I'm not hiding it. I'm not ashamed of it because I do it, in my opinion, the right way.
Mm-hmm.
When you are in network with an insurance, you have signed to agree to their payment. They will pay you for what they think they should pay you for. They are set rates that are often very, very, very low reimbursement rates. So I'll get a lot of patients that say, well, my surgeon didn't do the cosmetic add-ons with the deep flap, or they didn't spend the time to do X, Y, or Z. And I go, I don't know that you can blame your surgeon for that. They're not paid for some of those things. They're paid to do this, and this is what the code is that got approved. And some of these add-ons, they take time, they take skill, and if you're not paid for it, you can't expect people to work for free. But being out of network did for me was it bought me freedom. Freedom to practice the way that I want. I will spend every minute with you that you need at an appointment. There's no clock ticking. If you need an hour and a half of my time, you're going to get an hour and a half of my time. And in surgery, I don't sit there and I'm not doing any math of like, well, these were the code,
Right.
I'm going to do the deep flap operation or whatever flap operation to the best of my ability. And I'm going to sit there and do everything that I can so that you get the best result possible. And that is because I'm individually negotiating with the insurance company. So out of network means I have not signed a contract saying that they set the rates, they pay me whatever, and it's for these codes, period.
Yeah.
It means with each individual case, I have the opportunity to negotiate with the insurance company which codes I want to bill, why I want to bill them, and what I should get paid. And there are many different ways to be out of network. And I think that's why people get scared, because some people will charge cash for the whole thing and they will leave the burden to the patient to then go get reimbursed by the insurance company.
Right.
We try very hard not to do that. And I would say greater than 85% of our patients for flap surgery will come in knowing that I've already negotiated and signed a contract with their insurance, which is what we did in your case.
Absolutely.
That is called an out-of-network agreement or an LOA or a gap exception. There's a lot of different acronyms for it, but it's essentially a letter of agreement, an individual agreement between the surgeon and the insurance company about the patient's care.
Yep.
And in order to initiate that gap exception, every insurance company does it differently, but it usually requires the patient to call and say, hey, I want to see this doctor. I understand that she's out of network, but this is why I want to see her. And we have to prove in some capacity a deficiency in the system or the network. Well, why can't the in-network doctor do it? And so we know for each insurance company what those questions are that need to get answered. So we'll literally give the patient a script. This is what you need to say. This is what they're going to ask. Here are the answers. If you have, and I have a person hired in my office, and her job is to do this, to help patients navigate insurance.
And I will say that because for the people, I keep saying listening because I'm so used to listening, but for the people watching also, is that the insurance company is going to try to get you to go to an in-network doctor.
They will.
Because
they have to pay less to the in-network doctor.
So they started sending me a list. So in my experience, they sent me a list. I looked up all these doctors, and I would say 90% of them didn't even specialize in breast reconstruction. So that was my first argument. But I will tell the people that most insurance companies, what worked for me is they have a nurse navigator. And the nurse navigator, although she worked for the insurance company, she was definitely, I felt, on my side. And they ended up, I said, I already have a whole oncology surgical team, which is who you were going to work with. And I said, I don't want to switch that team also, which is what you guys are forcing me to do. And so I think in the end, she found one guy, and I went on to, first of all, I'm not having a male do this for me. Like, that was a hard no from the beginning. And second of all, I went onto their hospital website, and the reviews were, terrible. So I'm like, this is on the hospital website that the reviews, I screenshotted all of them. I sent them to her, and I said, this is a no. This is the biggest decision of my entire life right now. I'm not leaving it up to just an in-network doctor because that's what's convenient for you guys. So sometimes you do have to get a little aggressive. You do have to stand your ground.
You do. You have to be an advocate for yourself, which sucks, right? Because you're already sick. You're already going through something. So to then have to expend that much more energy and time to fight the system.
But it is worth it.
It's worth it. And what I like to do is just make sure that we are helping you fight. I'm not just saying, okay, I'm going to charge you all this money. Good luck. It's no. I'm going to help you do this. This is the person in my office. And on our end, we write the letters. We back up what you're saying. And my letter says, this is what I do, and this is how I do it. This is how many I've done. This is my efficiency in the operating room. These are my operative times. These are my outcomes. These are my statistics, right? Like they have like NBA players and NFL, but they're like stat
These are
cards.
my stats.
Here are my stats, right? And it corroborates what you say. And so I can't tell you the number of times the patient will say, well, they told me to go see this doctor. I'm like, okay, go see him. I know what I bring to the table.
And I couldn't even get in. That was the thing, because also, like you said, you're on a time window when you are finishing chemo. I think it was like a 4 to 6 week window, right? That I had to have my surgery. This doctor couldn't even see me for a consult for 2 months. So I'm trying to explain to them, I'm not on his schedule. So I think in the end, all of it happened. But even me being in LA, where there's everything here, hard pressed to find somebody that had the credentials and had the experience that you had. And once I kept like beating that into their heads, like, this is the microsurgery, she does this, she does that. Like, she doesn't just do the deep flap, which we're going to talk about in a minute, is, there's so much more to it, like you said, and even I remember being in physical therapy right after. I said, and she said that she's put my stomach muscles back together because I have 2 babies. And she's like, yeah, okay. And she's like, oh my God, like, this is amazing. And I go, yeah. So like you said, the silver lining that, it's not going to ever be exactly the same, but to be honest, it's kind of turning out a little bit better, than what it even was before.
And that right there is like music to my ears.
Right?
That is why I do what I do. I tell everyone I don't save lives, but I'm a quality of life surgeon.
Absolutely.
And when you are on the other end of this otherwise terrifying and difficult and trying journey, you then get to an opportunity to live your life again. And you're changed. You're a different person now.
Absolutely.
But my gosh, if you can look in the mirror and say, I like I love who I am.
Yeah.
And what I look like is as good or even potentially better, that there's a silver lining in this,
Mm-hmm. Mm-hmm.
then my gosh, I've done my job.
Yep.
And unfortunately, insurance companies don't care about that part, but there's a lot that you can argue. And, timeline is important.
Yes.
Can you get into the doctor that they sent you to fast enough? The surgery. Are they able to do the surgery in the fewest number of surgeries, potentially avoiding a tissue expander or avoiding an implant
Mm-hmm.
and going direct to natural tissue if that's your preference? Is this their specialty? Is this what they specialize in? Is this what they do all day long? And you have to educate yourself, unfortunately, to
Yeah.
know then what to tell these people
Yeah.
who are telling you, no, 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 go see this other doctor.
Mm-hmm.
And they use techniques of fear. They'll
Yes.
say, oh, you don't know what kind of bill she's going to send you, or you don't know this, that, or the next thing. And they will tell you anything
Mm-hmm.
to get you a network. But the reality is haven't sent you a singular bill.
No, I have not received a bill.
And
And I
I
will tell
never
you guys,
will.
the amount of money that I paid in 2025 for everything that was covered by insurance far outweighed. I did not get a bill from Dr. Srinivasa, even though she was out of network. So,
Because
yeah,
I
it's
negotiated with your insurance directly, and I
exactly.
got it figured out, and that gap exception then carries over to your revisions.
Mm-hmm.
And so we were able to get the totality of your reconstruction
Yep.
done, completely paid for by insurance
Mm-hmm.
with my skill set.
Yep.
And that's where I really would love to change the narrative around out-of-network
Yes.
doctors. I can't speak for everybody. There's
Right.
different kinds of out-of-network doctors, and they bill in different ways. But if you find one that understands the system and the
Mm-hmm.
logistics, and they work with you, and they're open and honest about it,
Mm-hmm.
then I think you really have the best opportunity to get the care that you want,
Mm-hmm.
but financially handled in a way that it should be, which is the insurance company that you're paying premiums to, they're paying for it. It's not coming out of your pocket.
Exactly. And so then also to speak to the women that maybe they've already gone to a surgeon,
Mhm.
maybe they haven't done anything yet, but they've gotten their first consult and they've kind of been told that there's only one option or there's only one way. So that's why I also wanted to ask you about if you can speak to a little bit of the different options that there are out there for breast reconstructive surgery. Because when I went, I'll let you speak to the different kinds and explain them.
I was going to kick the question back to you. I think this is best illustrated if you tell me what you were told.
What I was told in the
because
beginning?
it's pretty common.
So in the beginning, I went to a surgeon who was recommended to me from the cancer center that I go to. Went to her, went with my mom, and I looked her up first, same as I did with you. Seemed to have good credentials, seemed to have done a lot of surgeries. I saw before and after pictures. And she told me that she was going to, number one, she was going to operate based upon what my cancer was when I started treatment, which it was stage 3, and my tumor was the size of a softball. So she was going to, I could not save my nipple. She was going to take my nipple.
Spoiler alert, your nipples are still
My
there.
nipples are still there. She was going to take my nipple. She was going to remove my lymph nodes. She was also going to remove some skin around the nipple because my tumor was so close to the skin when it started. But when I saw her, my chemo had started in January, and I believe I saw her, I want to say it was like either late February or March. My tumor had already shrunk to the point that it was like, now it's a golf ball. So she was like, but we operate based upon what it was when it started. And I'm kind of thinking, then what the hell's the point of the chemo, right? And so she tells me that. She tells me also that I do not have enough tissue in my stomach to do the deep flap reconstruction. So she's going to have
Spoiler
to supplement.
alert, you had a deep
I
flap.
did. So I also, she was going to have to supplement with implants, which meant I was going to get an expander. And I was going to have to go in every 2 weeks, get it filled up till I was the size that I wanted. So all in all, the surgery overall was going to take start to finish over a year and a half, she said maybe. And personally, I had already been hospitalized because my chest pore got infected. So I did not feel good about putting a foreign object in my body. I remember getting in the car with my mom after, and I was like, this sounds terrible.
The surgeon that you saw was in network or out of network?
In network.
In network, okay.
Well, no, actually,
I thought they were out of network.
She did end up being out of network.
Yeah.
She saw me, but she actually didn't check beforehand.
Yeah.
So they ended up calling me weeks later saying she was actually out of network.
Yeah.
So I was led to believe that she was in network, and turns out she wasn't anyway.
And your story is really, 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 really common. So, this speaks to a couple of concepts that I think are really important. Number one, the breast surgeon and the plastic surgeon are a team. They're your dynamic duo. And I always say, if given the opportunity, pick who you want to be your Avengers. And if you have PPO insurance specifically, you have the freedom to see who you want to see. And I am double board certified, so I could practice breast surgery if I choose to, but I prefer to work with people who did a fellowship in breast surgical oncology. And, with every 6 months that go by, the data, the literature, what we know changes and evolves. And we're in actually a really, I would say, like the renaissance of breast cancer therapy, because we're really changing the way we practice for tumor-specific, biology-specific treatment, meaning it's individualized care. Your tumor is not the same as another person's tumor. It's different from the third person. The biology of your tumor and who you are and how old you are and your health status, everything can be taken comprehensively to make a plan for you. And you had a HER2 positive tumor?
No, triple negative.
Triple negative.
Yeah.
Okay. With triple negative tumors, we've made tremendous strides. And did you get Keytruda?
Yes.
Okay. With the addition of Keytruda, we've seen a really impressive number of patients come out with a complete pathologic response, more than we ever saw before.
Which is what happened to me.
Exactly. And prior to to really getting to that point with triple negative, we were there with HER2 positive disease. We had such good drugs for it, we still do, for HER2 positive disease, that we were seeing the tumor completely gone. Softball-sized tumors, completely dead, gone, no longer alive in the body. And so then the next question then becomes, do you operate based on the data you had at the beginning of chemo or at the end of chemo? And I can't make a blanket statement because it depends on the tumor biology, and it depends on the treatment that you got, and it depends on how much resolution of disease that you personally show. But I have my Rolodex of breast surgeons that I work with that I know that are at the top of their game, that are up to date with the literature, that are part of these trials, that are practicing medicine in the most cutting edge way possible. And I sent you to one of those women.
You did.
And I said, you know what, get a second opinion, because if she says the same thing, then fine, that's the answer.
Yeah.
But my belief, from what I know and how I've kept up to date with the literature, is that there is a different way that we can approach this, that is supported by the data, that should give you, again, the same long-term outcome, right? As a plastic surgeon, nothing I do is that important if I don't also optimize the cancer treatment, right? So I will never interfere with that. But I will send you to doctors that I trust. And, that surgeon who saw you reviewed your MRI. I think, did she repeat your MRI even?
I did get another one, yeah.
And then studied it and said, hey, we have really good data to support that if the tumor is not at this point in your skin or in your nipple, we can save it. And we do this precursor surgery where we check that skin and we check the tissue under your nipple and make sure we're not guessing here.
Right. And I love that you guys did that too, because I felt like that was was able to make such a more informed decision.
Informed decision making.
Rather than just like, well, this is what it was in January.
Yeah. So we tested it. We had the pathologist look at it. We re-imaged you and we said, look, there's no tumor there. We believe that it is safe to do a nipple-sparing mastectomy. Here's the data. Here's the research. Here's, what we know. And it's overwhelmingly positive data, right? If the cancer is not in that tissue, you've had a complete response, then we can safely recommend alternative options to you instead of just removing everything. And we do it all the time. We weren't experimenting on you, right?
Yes.
We had this data to show you. And so we did that, and we were able to optimize the blood flow, save the nipple. And the other touch point was whether you needed a tissue expander, which is a temporary device. And a lot of plastic surgeons will start with a tissue expander because they work with a variety of breast surgeons. They're unsure of the quality of the mastectomy that's going to be done. Is there going to be enough blood flow? Is it safe to go straight to the flap? Also, time matters, right? If that person takes 8 to 12 hours to do a bilateral deep flap, they're not wanting to tack it on to a 4-hour mastectomy operation, especially if they can't operate at the same time.
That is what she had told me too. Yeah, we do not do this at the same time.
She said that because she works with other plastic surgeons. But when her and I work together, it can be a completely different story.
Yep.
And I work with breast surgeons where I can work at the same time as them. And I start at the same time that they do so that we can work together so that saves time. Also, I'm a highly efficient microsurgeon. A butt cut to close, which is, from when you first make incision to close, the last stitch goes in. Bilateral deep can be 4 to 6 hours. It doesn't have to be 8 to 12 hours. And we can do it safely, and we can do it at the same time as the mastectomy. And when you can do that, and you can offer patients that, and you give them the opportunity to not have a foreign body which can then get infected. Like you said, you already
Right.
had a chest port that was infected. That is something we have to take into consideration. If a
Mhm.
port got infected, you are definitively at higher risk for then a tissue expander or an implant getting infected, right? So we were able to have these conversations. We were able to meet multiple times. I was
Mhm.
able to pick up a cell phone and call your breast surgeon, whom I work with regularly, and
Mhm.
say, hey, how do you feel about this? Can you look at this patient top to bottom? Can you do a consultation? Can you do a second opinion? And what we were able to then deliver to you was reconstruction with a flap right off the bat, no foreign body, hidden scar on the bottom
Mhm.
of your breast, and all natural tissue.
Yep.
You don't need to have an implant. And it speaks to the value of the team, working with the right breast surgeon and the right plastic surgeon who work together, and the value of a second opinion.
Mhm. And I remember going to you in the beginning and telling you, like, "I don't care. Just take my nipples. It doesn't
Yeah.
matter," and you were very kind and very patient and like, "I really want you to think about this because we have." I think for me, I had already been told so much by that other surgeon that I'm like, "How can it be so different?" How can this be possible when this other surgeon
It
told
kind of
me
freaks you
this?
out,
A
right?
little
When you
bit.
hear totally different things, you're like, well, who do I trust? Is
Right.
she the quack? Or like,
Right.
what's
Right.
going on here?
But like you said, you have your stats, you have in this day and age, it's like you can go on Instagram and you can see your before and after pictures of, your business and what you've done and patients pictures. You
I
talk
always
about
say
it.
it's a red flag if they won't show you before and
Right.
afters.
Or it's too hard to find them. Like I had to go, I said, okay, can we just do a virtual consult? Like I need you to come here in person. So I can't see anything until I drive 2 hours to your office and even like see what you've done before. Like why are you hiding it? Just let me know. But yeah, and I remember saying, like, I don't care, just take my nibbles, it doesn't matter anymore. Cause I felt defeated, honestly.
Mhm.
And you were like, no, think about it, because we have this other surgery. We're kind of I think you guys described it like we're basically doing like half a mastectomy 2 weeks before,
Mhm.
right? And I was like, okay, well, I guess." And I went home and I thought about it and I was like, "You know what? Let's just try. Let's just try." And I'm so glad that I did. And I remember telling you, you're like, "I think you're going to be really, really happy." And then and then to find out even better is like you find out early, like, "Oh my gosh, if there's no cancer in my nipple tissue and there's no cancer in my lymph
We
nodes."
also check the lymph nodes,
Right.
right?
And so when that other surgeon said, "I'm taking your lymph nodes," that was the same thing she had said. And then to have none of that happen was just like, wow, she was just gonna do so much to me that was so
I mean,
unnecessary.
your lymphedema risk can go up to 40% with a total nodal dissection, right?
Mhm.
And to avoid that even
Right.
can really dramatically change the course of your life.
Right. And I still have done, I will tell anybody watching this, I've still done, and I think they recommend it for everybody, at least the hospital that I went to, is physical therapy. Because
Absolutely.
even though I didn't have my lymph nodes removed, that was probably the
You
biggest
had them
struggle
sampled.
for
Some
me.
of them are removed,
Yeah.
but we didn't take all of them.
Right.
And in some patients, you do have to take all of them. So
Right.
I don't want anyone to watch this and come away with, oh, well, I didn't need to have that done.
Right.
Each case is
Everybody's
different,
different. Yeah.
but we're in the renaissance of
Right.
breast cancer treatment and reconstruction.
Mm-hmm.
We are doing fewer and fewer total node dissections, axillary node dissections, because we have realized that the chemo is so good
Right.
that we don't need to at the rate that we did before.
Mhm, mhm. Yeah, and the physical therapy for me is what's been huge because I didn't have that range of motion in my arm, even with doing what I did. I didn't
Mhm.
have the range of motion. I couldn't straighten my arm. I couldn't put it all the way up. But, that's when the hospital stepped in and said, "No, like we recommend physical therapy." It's been amazing for taking care of my scars. It's been amazing for doing the cupping and bringing back some sensation. And that's another thing that you talk about is sensation preservation. So can you explain a little bit about like what that is for people that have probably been told you're going to be numb from the neck down?
Yeah, yeah. Um, as we evolve in breast microsurgery and breast reconstruction, one of the battles that we want to take on is the ability to preserve as much sensation as possible.
Mhm.
Post mastectomy, there is some degree of numbness, and that varies based on the kind of mastectomy you had, how much skin was removed, etc. Part of that has to do with how the mastectomy is done, and part of that can be how the reconstruction was done. So again, it goes back to the duo. Both surgeons matter. If the person doing your mastectomy is going much thinner than they need to, there's layers. There's
Mhm.
skin, there's subcutaneous fat that's not breast tissue, and then there's breast tissue. The mastectomy is meant to take out all the breast tissue, leave a little thin layer of fat in the skin. Well, some surgeons won't leave that layer of fat and they'll go right up to the dermis, which is that thin layer right under, as part of your
Mhm,
skin.
mhm.
Well, A, that can lead to necrosis, and B, you're really minimizing any chance of meaningful sensation recovery. So there is a way to do a thoughtful, oncologic, perfectly safe from a cancer perspective mastectomy where you're removing all of the breast tissue to the best of your ability and just leaving a little layer of fat with that skin. And when you can couple that with really cutting edge reconstructive techniques, which includes nerve grafting, and that can be done with an implant or it can be done with natural tissue, or borrowing a nerve when you harvest the tissue and connecting that in the chest. There's a lot of different ways you can go about it. Natural tissue reconstruction gives those cut nerve endings a place to grow into. A thoughtful mastectomy that preserves as many nerves as possible is important. And then nerve grafting is another part of it. So there's all these techniques that we can pull from.
Mhm.
And when thoughtfully done together, you give the patient the best chance of retaining as much sensation as possible. Sensation is layered, it's tricky. There's protective sensation. There's, do you feel it when you give somebody a hug? There's, what
Mhm.
if you spill some hot tea on yourself? Do you feel that it is too hot or do you feel too cold? Erogenous sexual sensation, right? There's lots of different kinds of sensation. There's light touch, there's deep pressure. We want for you to retain as much of it as possible.
Mhm.
And you don't want to do too thick of a mastectomy. You don't want to leave behind breast tissue.
Right.
That can increase recurrence risk. You don't want to do that. But you want to do a thoughtful, appropriate mastectomy. You don't want to go too thin either.
Mhm.
So, working with the breast surgeon who I know does a thoughtful mastectomy and can get me the right layers maintained while still safely removing the breast tissue, and then doing a natural tissue reconstruction, which does give those cut nerve endings a chance to grow back into the natural tissue, gives you a chance to retain as much sensation as possible. And I think that's a really meaningful part of breast reconstruction.
Mhm. And I think, like, you being able to see that from the outside, because when somebody like, I know when I was in it, I was just like, "I don't care. My breasts betrayed me. They don't even belong to me anymore."
Yeah.
But you get beyond that, and that's why it was said, like, in the beginning, I'm so glad that we're doing this interview, like, 6 months after, because, like, for those of you guys watching and listening, like, that first surgery, like, it's not great,
Nope.
and you do the
You feel like you
mastectomy,
get hit by a bus.
you feel like you get hit by a bus, you look like you got chopped up, because no matter what it is, like, in the beginning, I mean, you have crazy
Incisions, you're
incisions,
bruised,
you
you're
have drains,
swollen.
yes. It's not pretty. But once I did that first revision a couple months after, we removed the extra flaps of skin, we kind of revised the scar, we did a little bit of fat grafting. Like, I was so happy after that first one. Even the first day I went home and I was like, I have to peak, I have to peak. And I was just like, oh my goodness. Okay. I can, like you said, I can see the silver lining, because now it's like, the fact of the matter is the scars will fade, right? Yes. Do I have a scar hip to hip? Yes. But also the other thing too, I think when you talk about the silver lining, it was really important to you in the beginning when I was meeting with you and you were talking about making the scar as low as possible.
Yeah.
There's a lot of surgeons
Let's
that
hide it.
don't pay attention to the donor site. And I've seen results on your business page of people that have already, so for the people that are watching and say they've already had a mastectomy, it's not too late for them to come to you
No.
and see you.
You could have even already had your deep flap.
Yeah.
And I can add flaps for more natural tissue. I can revise somebody else's work. Obviously what I can do is limited by what was done before me,
Right.
but making the belly button look as natural and cute as possible, borrowing techniques from the cosmetic world so that
Mhm.
I'm doing as much as I can for the long-term aesthetics of
Yeah.
what's done, right? Making the scar as low as possible so you can wear crop tops or two-piece bathing suits and have the scar be hidden. Super, super important. Preserving the muscle and the nerves so that you don't have loss of function in your ab muscle.
Mhm.
Super important. Fixing a diastasis or where your abs maybe have drifted apart over time, potentially just due to age or pregnancies, bringing that back together, bringing in the waistline. All of these things are super important. And you're right. A lot of people they come in and they're like, I don't care.
Right.
I'm so tired and stressed and scared.
Yeah.
Just get me through this.
Yeah.
But I have the benefit of knowing so many women who have been through the process and seeing when it comes to a point where they do care.
Yeah.
So I get to care for you in the
Yes,
beginning.
I agree. And like, maybe something sticks out, or you can speak to those moments where you can see that a woman's really like, now she's starting to feel like herself again, maybe, or maybe even better. And then, like, what does that look like for somebody who, maybe they're still in the thick of it and they're just like, you can't even see that yet. And I can tell you guys, like, it's going to come. I'm still having another revision actually in a couple weeks, and that's totally up to me. But at the point, it's funny because when you suggested it, I remember saying same thing. No, I think it's okay. And I went home, thought about it, talked to my parents, talked to my sister, and everybody kind of was the same consensus. Like, you've come so far. Why would you not just do one more, to just have the results be as good as they can be? But for the woman that like she finally starts to feel like herself again, like what does that look like for you as a surgeon?
Well, I can always tell because they come in a cute outfit with
Mhm.
maybe a little bit of makeup on or a little skincare on. And it's cute because the girls in my office, they've been with me for so long, they can pick up on it and they'll go, you know what,
Yeah.
she's feeling better. And we can tell, right?
Yeah.
There is a change in the way that they're engaging with the world around them when, whether it is that you got the good news back from the pathology or you got kind of the clean bill of health from your oncologist or you
Yeah.
don't have a follow-up for another 6 months or a year. There are little things that can happen along the way that make you feel a sense of normalcy again.
Yeah.
I will say, I think part of my job is also respecting that there's a lot of anxiety that will linger. There's a lot of PTSD that will linger. And I try to be mindful of that
Mhm.
because ironically, I actually think sometimes it's the plastic surgeon, the reconstructive surgeon that sees patients much longer than some of the other doctors that are
Right.
part of your team
Yeah.
because we're following your reconstruction. And so I try to always remember that, you know what, they may be looking better and feeling better, but there is a PTSD and there is an anxiety to it. And they are always waiting for that next scan, the next image,
Mhm.
whatever it is. But I always like to say it's nice to at least move on to the next chapter of
Right.
the book. And if I can help you move on to that next chapter, because some people feel very stuck in that same chapter,
Mhm.
right? Because they're not happy with their reconstruction. They're not happy with how they look. So they feel like they're unable to move on
Right.
from where they were. And it's just this nightmare that doesn't end.
Mhm.
So I think if you're in the thick of it and you feel like you're not going to get to the other side of it, I think it's hard, and I have personally haven't been through the breast cancer journey, so I can only speak of it from the provider side. But I think things that women do to help themselves is to have an advocate, have somebody come with you to your appointments to help ask the questions. Vibe check,
Mhm.
right?
Mhm.
Is this the right doctor for me? Am I getting the right vibe from the office staff, from the physician, from the facility? Help ask questions that you maybe have forgotten, help you remember the answers that were
Mhm.
given. I think having an advocate is really, really important. I think always looking at how far you've come. Right?
Yeah.
Well, I know I feel like there's so much more to go, but what have I gotten through so far?
Yeah.
And I really think empowering yourself to switch providers, if you feel like that will help you, I think is
Mhm.
really important because sometimes women are told things which such it's like it's so definitive,
Mhm.
right? Like this is your option. This is what we can do.
Yeah.
That they feel like, okay,
Right.
that's what we can do. But oftentimes there are other options. And if you really do want something,
Mhm.
say it is you really want natural tissue reconstruction, or you really want above the muscle direct to implant, or you really want a revision, whatever it is. Or you think that there's a deformity, but the surgeon says they don't see it.
Yeah.
Get a second opinion from someone who's an expert in that thing that you want. And like if you see two or three doctors and they're all telling you the same thing, then probably, unfortunately, whatever
Yeah.
it is. But more often than not, I would say far more often than not, there is an alternative. You just need to
Mhm.
find the doctor who's willing to spend the time and discuss those options with you. And everything is a risk benefit analysis.
Yeah.
Sometimes flaps don't go well. I'm a flap surgeon, and that's the first thing I tell people.
Yeah.
Hey, by the way, this is the risk of failure. This is what happens if the flap fails. Because it's important you understand that every option has risks and benefits.
Mhm.
But you got to be informed about your personal list of goals and what you prioritize so then you can pick what's best for you. And that may be different than what the surgeon would pick for themselves
Right.
or what they would encourage a family member to do or what your friend did. And that's okay.
Mhm. And I think after it's so funny because after meeting you, I got second opinions on everything because even just 2 months ago, I had an option, like, through my work to get someone to just look at all of my medical records, a totally different oncology team. I said, "Well, why not?" They reached out way too late, say, "Oh, I think you've been diagnosed." I'm like, "Where have you been? I already did chemo. I've already had 3
Yeah.
surgeries. It's already gone." But she looked and, just to get that same, like that peace of mind, like that knowing. And she was just so complimentary. She's like, "I think your team went above and beyond. I wouldn't have done anything different. I think they were so on top of everything that's happening." Like you said, I mean, things are changing all the time. Even, for example, like I opted to do immunotherapy for 6 months after surgery,
Hmm.
even though I had a full pathological response. My oncologist told me not to. She told me that I didn't need to. But I did my own research. I talked to people and I said, I feel that the benefits outweigh the risks and I choose to do it. And the oncologist that gave me the second opinion, she said, this is the new standard of care now to do immunotherapy for a year. And I'm like, so that was just a major coincidence. But I would say the biggest thing too is like listen to your intuition, listen to your gut. If it's telling you that you really want something, if it's telling you that something doesn't feel right, like
Yeah.
that was the biggest thing for me.
Listen to your gut.
Yeah, is it
Absolutely.
didn't feel right, and I knew I didn't want that, and I was like, "I'm not settling." And I mean, luckily for me, I had been sharing my whole entire journey on social media as it was, and so many people had already connected me with, "You should talk to her. She's been through it. She's done this." And that's how I came across you because I had a former coworker that was a patient of yours, and I reached out and said, "Hey, who was your surgeon? What did you do?" And to speak to how you communicate with people, she said, "Let me reach out to her." Within an hour, you guys, I was on the phone with Dr. Srinivasa because she sent me a DM like, "This is the technology that we're in these days," and she said, "What's your number? Can I just call you?" And you called me and I hung up the phone and I was like, "She's the one. She's the one." Because of that, because it wasn't, "Oh, can you call my office and schedule an appointment and then maybe I'll see you in a month?" Like you said, you're in the thick of it and you're spiraling, right? And you're
Yeah.
feeling like you have no other option. So to be able to come in that time in that moment and like, "Hey, it's okay. I got you. Like come in, talk. Let's." And there's no risk to getting a second opinion.
There really isn't. And I do think it's a slippery slope. I will see patients sometimes that have gotten 7 opinions,
Mm,
and I go, "Man, you're gonna muddy the water." So
yeah,
be thoughtful about who you go see,
right.
right? Make sure they're an expert in what you do. Like, just do some basic vetting. Do you have access to their before and afters?
Mhm.
Vibe check and gut check. I think, what does your gut tell you? Do you feel like you're in the best hands? If not, get a second opinion. Um,
I live my whole life that way now. Vibe check,
yeah.
gut check.
Yeah. Yeah. And then when you go in, what's the vibe that you get?
Yeah.
Do you feel welcome? Do you feel like you're being heard? I am not perfect, but one thing I will tell my patients is I am here with you through thick and thin. If you have a complication, you have my cell phone number. These are all the people you can get a hold of in my office. This is how we'll deal with it.
Yeah.
If there ever comes a point where you're not happy and I feel that I have done all that I can do, I'm going to phone a friend
Mhm.
and I'm going to send you to somebody else because there's no ego in this. I just have to do the best that I can do for you.
Yeah.
And not every patient loves me either, right? Some patients are really turned off by the fact that I'm on social media, or they don't
Mhm.
like that I have maybe political opinions or that I dress a certain way or whatnot.
Yeah.
And that's okay. Go with your gut, go with the vibe, pick the right team for you.
Mhm.
And if you feel like you're in the thick of it and you feel lost and you feel like you're not being supported, maybe reevaluate then. Okay, who's on my team?
Yeah. I agree. And then the other thing that you've done now is you have a new venture is your skincare line, and I wanted you to speak about that and why you created it in the first place because obviously you have all of these other things going on, but I just feel like you have such a servant heart and you obviously create out of the need that you see.
Yeah, I started Avara, which is my skincare line, and it's something that I've been wanting to do for a long time. But for people who know me well, even my patients, I'm very purpose driven. I have to really feel like there's something that I can do better or
Yeah.
different. Otherwise, I don't bother.
Mhm.
I don't do facelifts because I'm not going to do it better than all the other people in LA doing facelifts. But I do a lot of microsurgery because I feel that I do it the best. So when it came to skincare, even though it's something I'd wanted to do for a long time, I didn't because I needed purpose behind it. And I found that purpose through my patients who I'm a chatty Cathy in clinic. Everybody knows I'm always running late because I'm always like, how are the kids? Where'd you go on vacation? How's this? How's that? And so we get talking about eyebrows. We get talking about hair. We get talking about why does my skin look like this, Dr. Srinivas? I've never had breakouts. What's going on?
Mhm.
And we start talking about, well, did you have hormone positive disease? Do they shut down your hormones? Okay, let's talk about menopause skincare. Let's talk about, and in talking about that, I realized there was an absurd void in health inclusive skincare. You can go to Sephora and there is a gondola for everything
Mhm.
except for health inclusive skincare. What about perimenopause? What about menopause? What about IVF? What about childbearing? What about postpartum? What about autoimmune? What about cancer? How do you know what's safe for you and what you can use? Not all breakouts are acne. They're not necessarily caused by bacteria. They can be because of a damaged skin barrier
Mhm.
from chemo, from radiation, from dehydration, from nutrition, from a massive drop in estrogen because of medications that you were put on, right? And nobody's talking about it. So I found my purpose and I found that, okay, I'm going to create skincare that is health inclusive and you don't have to go digging for the purpose. It's front and center. You go to the website, you pick up the package, you know what it's for. It's consciously created. It is the ingredients were handpicked. A lot of people don't know this, but when you go buy a lot of doctor skincare brands
Mhm.
or even non-doctor skincare brands, they're coming from a factory. There's these companies
Mhm.
that have pre-made formulas. So you go to them and say, I'm Dr. So-and-so, and I want Dr. Srinivasa skincare, and I want a vitamin C. And they'll go, okay, here's our catalog of vitamin Cs, pick what you want. Or maybe they'll tweak an ingredient or two or a
Mm.
percentage or two. Not the way I'm going to do it. I sat with a private chemist who's an expert in the field, and we block by block put in each ingredient. I went through 28 revisions for the Face Restore, which was our moisturizer, because I wanted it to be perfect.
Mhm.
And I'll say, no, you're never going to create a product that 100% of people like, right?
Right.
That's not the goal. But I need the right person to like this product. So I put a little eucalyptus in it because I know that eucalyptus is one of the most universally accepted scents, especially if you're nauseous going through chemo.
Mhm.
It feels and smells like a spa.
Please don't put lavender in my stuff.
I won't, because lavender can actually be very triggering
Yes,
for a lot of
yes.
people. So if I was going to do something scented,
Yeah.
I was going to do it intentionally. So I
Mhm.
chose eucalyptus because it's so well tolerated, and especially for patients going through chemo or maybe having a little bit of nausea or whatnot, it's immediately calming. It's immediately
Mhm.
soothing. And it is highly unusual to have a eucalyptus allergy, and it is not triggering like other scents and scented products.
Yeah.
The consistency, I wanted it to be thick and rich without being gloopy. Things like that. I really went through each thing that I care about, that my patients care about, that women care about, and each ingredient was handpicked, and the percentage and how much of it that I used was so intentional because I wanted to be able to create skincare that, like, I want Avara to be synonymous with, okay, this is safe for me to use, even though I have rheumatoid arthritis, even though I'm going through menopause, even though I'm pregnant, even though I'm getting chemo.
Yeah.
I wanted people to know that it's safe. And so safe is one thing, effective is the other thing. So focusing on efficacy, what are the ingredients that people really need? And what I realized is that a lot of people are deep into the actives, retinols, AHAs, BHAs, and that's
Mhm.
fine. They're all great ingredients. I use them regularly. But if your skin barrier is not intact, none of that's going to work for you as well as it could.
Yeah.
It may even cause you to break out or get redness or trigger your rosacea. So focusing on the basics. I always say I like to make moisturizer sexy again. Wearing and using products that are intentionally created to restore your skin barrier. Keep doing the actives that you want to do, hopefully under expert guidance. But I don't want to take away from that. I use those actives too, but I use them in conjunction with my own skincare line to make the most out of it. And we've seen such an incredible response, and I'm so grateful for that. It's been we're not even at a year yet. We launched in May of 2025, and it's been, I'm like getting goosebumps talking about it. It's been so well received. And I think that speaks to the craftsmanship,
Yeah.
which I care a lot about, but I think it also speaks to the void, the white space that was in the market
Yeah.
for health inclusive skincare. That's sexy and pretty.
Yeah.
The packaging is beautiful.
It's beautiful.
It smells great. It looks beautiful. It's sexy on your counter. It hits all those benchmarks, but it's also health inclusive and it's good for you.
Yeah. And I think I know that was like a super deep dive that I did in the beginning. I mean, I went a little crazy like down the rabbit hole because I was like throwing everything away in my house. I was like, "Oh my gosh, this is toxic. This has that." And to just know that there's something, also created by a breast cancer surgeon, for patients it's just phenomenal because you do start second guessing everything you're putting in your body, everything you're putting on your
Yeah, of
body. It was
course.
like the pans I was using, the water I was drinking, my detergent. I mean, I went nuts on it.
I will say the regulations in the US for cosmetic products they're improving. There's room for change.
Mhm.
But I do know, we're obligated obviously to lead with honesty when it comes to our ingredients and what we're using.
Mhm.
I also think it's a scary place to be when you've been diagnosed with breast cancer and you are second guessing everything. And there's a lot of grifters that will take advantage of that
Absolutely.
and try to sell you things or sell you on ideas that are untrue. So it's a
Mhm.
scary place to be. And even the word clean, you see that little green
Yeah.
circle. It's kind of an unregulated term. We don't know what it means,
Right.
right? And it can mean different things for different brands and different retailers. So it's a hard place to function then, because to me the best way to do that is, look, I don't know, that word clean can mean something different for different companies and at
Right.
Sephora versus Ulta. Sure. But I can tell you what's in my product because I
Mhm.
built it from scratch, ingredient by ingredient. And I can tell you where they are sourced from, and I can tell you how they were put together and the lab that created them, and I can be transparent about that, and I can know that I cared about it enough
Yeah.
to vet these things for you guys on your behalf.
Mhm.
And I to me that's where my brand is different
Mhm. Yeah. Well, and
because
then you came out with when I saw when you came out with the eyebrow and the eyelash,
yeah.
because I didn't lose my eyebrows and my eyelashes till after chemo.
Mhm.
So I thought, "Oh, I'm good." I mean,
Yeah.
obviously I lost my hair, but I was like, I felt okay because I had my eyebrows and my eyelashes. I finished chemo in May and it's like mid-June and I'm like, "What is happening? My eyebrows and my
Hair growth
eyelashes are falling out
happens in
now."
phases, and where your hair is in any given phase can be different.
Mhm.
Um, and hair loss is devastating, right? Whether
Yeah.
through chemo or other causes. And that's the thing. My products, when I made the lash longevity, it's prostaglandin free. It's carbon black free. I took what's evidence based.
Yeah.
I'm not going to create a bunch of fear mongering. I'm not going to sell you a bunch of things that are not backed by science, but I'm going to create products that work based on testing, based on science. And I'm going to leave out what we
Mhm.
know is not good for you.
Yeah.
And people also questioned, like, why a moisturizer? Don't you think there's enough moisturizers? And I said, there's not this moisturizer.
Mhm.
Why this lash product? Because I want to do it better and I want to do it different. And it was very purpose driven for me. And it's been really rewarding because I get an opportunity to connect with my community. And so, just the other day, there was a woman going through chemo who was talking about Avara on her TikTok page. And I immediately told the team, I want you to reach out. I want her to be honest about what she loves, maybe
Yeah.
something she doesn't love. What does she think about the packaging? Does she have any reaction? What was she using before? I was like, ask her what else we need to send her. We'll send it for free. I want to know what
Yeah.
people think. And what's so cool about Avara for me is I had initially created it for my patients, but in testing it, I became addicted
Mhm.
as not a cancer patient because I realized all women are going through something. And our
Right.
tagline became for the woman who is healing because all of us are going through something. I've had 3 kids. I know what being postpartum is like. I turned 40 this year. I know what hormone changes I'm going through. I
Mhm.
know I work a lot. I'm chronically dehydrated. I travel, I have friends who are going through menopause or IVF, um, or, again, postpartum. There's just so many things that come with women's health
Yeah.
that women are going through, and really all of us are healing from something.
That's
And
true.
the feedback that I've gotten, I have a best friend who's a colorectal surgeon, and she just had little hormonal breakouts, and she's busy. She also has 3 kids, and she's never had the time to care.
Yeah.
And I said, get the spray. Like, let's see how the spray does for you. And I was like, I'll send you as many as you need. Try it. And she called me and she goes, oh my God, the spray has changed my life. All those weird breakouts I was having completely gone. And
That's
it was
amazing.
such a cool feeling because she's not someone who's gone through cancer. But
Right.
again, speaking to, we're all going through something, and we're just now starting to see that emphasis on women's health and
Mhm.
really, whether it's endometriosis or breast cancer or menopause, we're finally now seeing the emphasis being placed where it needs to be, focusing on these conditions where, I mean, menopause is such an example where it's like, oh, everybody goes through it. It just is what it is. And
Right.
it's like, no, it is a massive change in the very axis of hormones in which your body functions. And I always think, like, if it happened to men, there would be
Oh, yes.
centuries of research on
Of
this,
course,
right?
right?
Endometriosis, another one, right? Women are just told, like, oh, periods are meant to be painful, or like
Yeah.
infertility happens, when in reality, there's actually a disease process going on that we can intervene and we can treat to optimize, a woman's experience with their menstrual cycle and with fertility. And so we're finally now starting to see the match get lit to talk about these things. And I
Mhm.
think that if there was ever a time to introduce health inclusive beauty and health inclusive skincare, it's right now.
I love it. I love it. It's amazing. I actually just ran out of my other eye cream and I was like, I'm gonna take the leap and I'm gonna try the Avara because it looks amazing. I watch you put it on all the time. So I was like, we're doing it. But I do want to ask, like, for the woman who is going into her first consult,
Mhm.
like for her breast reconstructive surgery, like, what would you tell her?
I would say there's always some questions I recommend. How much of your practice is breast reconstruction? What percentage?
Mhm.
And if say you want deep flaps, how many deep flaps do you do a week? If they answer with how many they do a month or a year,
Mhm.
there's people who are doing it more often. If it's direct to implant that you want, how many direct to implant reconstructions do you do a week? Ask the questions, ask for before and afters. If I have an emergency concern, how do I get a hold of you? What's their answer? Is it a call center? Which call centers are fine. That's not a problem.
Yeah.
But how many steps before they can get a hold of somebody?
Mhm.
When you, even just when you make the appointment, how easy was it for you to make the appointment? Does a human being answer the phone within a reasonable amount of time? I mean, we have a call tree, but it's pretty quick. We have
Mhm.
direct numbers to everybody,
Yeah.
right? We have emails that they'll get back to you within 10 minutes sometimes because
Yeah.
they're constantly checking their email. My staff check their email on weekends. I always have my phone on me. Um, ask those questions and ask for before and afters and realize that we don't work in isolation. So a lot of what I do is me, of course, and my surgical skill, but it is how well that you were instructed to take care of your incisions after. Were you given good post-op instructions? Were you told to go to physical therapy? Were you given a certified lymphatic therapist? Those things are, you talked about PT before.
Mm-hmm.
We have prehab in our office. We give you the referral even before to how to optimize your range of motion before you go into surgery. We will connect you with lymphatic therapists that we recommend to get started as soon as you're ready. Hyperbaric therapy. Are you getting enough vitamin D? Are you taking your protein? How comprehensive is your care? I think these are all things that you can check and sort of screen for as you go into the process and go into your first consultation. I can't possibly answer every single question that you have in the first visit.
Right.
And I'm honest about that. But what I say is, let's make a follow-up visit.
Mm-hmm.
Call the office. Let's chat. Let's Zoom. I can call you on the phone, have another visit. Maybe I'll have my nurse practitioner check in with you. Why don't you let all this percolate? Think about what we've talked about. You're going to have questions. I want you to have questions. Yeah. Let's chat in about a week. That's how I end every consult. It's not like, okay, let me know when you're ready to book surgery.
Right.
Of course, if you're ready, great. We'll get that ball rolling as well. But let's talk more. So I think these are all kind of things that you can look for to avoid the red flags.
Mm-hmm. I would agree. Do you think there's anything else that you wanted to mention that we haven't covered? I feel like this has been we've covered so many things so far.
Right? I should say gut check, vibe check.
Gut check, vibe check.
I'm going to say it again.
That's going to be like our motto for 2026.
Yeah, gut check, vibe check. Do you feel good about it? If you're feeling really lost in your care, I mean, obviously there's going to be a sense of sadness and a sense of loss and grief when you get a breast cancer diagnosis and you're moving through your therapies and excuse me, and anxiety, PTSD. These are all very normal things, which is why I think mental health is so important as part of this as well.
I agree.
I'm very quick to recommend mental health services as well. Those things are going to be normal, but are you doing the best? Are you being provided what you need to maneuver these things the best that you possibly can?
Yeah.
And if you feel like the answer is no, your doctors aren't listening to you, you don't feel like you have enough ancillary support, then I would say revisit who your care team is.
Absolutely. Get a second opinion. It doesn't cost anything. And you also deal with patients, even if they're not from here, right? Because you guys have recovery centers. People fly here.
All the time.
They come see you.
Yeah.
The recovery center is beautiful. That's where I got my drains taken out.
Yep. I have about 60% of my patients are not local.
Really?
Yeah. Meaning not in like LA or LA greater area, flying in, driving in, coming from other countries, other states. We have a really extensive support system. And I think, if anything, it speaks to how difficult it is for some people to find a comprehensive care team where they are, which sucks. I wish more than anything that everybody could run a practice that provides everything that the patient needs. But, we are also, as physicians, battling a lot of factors when it comes to insurance and hospitals. And, sometimes I can't fix every problem for the patient and I get frustrated, and it's because we're dealing with an insurance company or we're dealing with the hospital system. And I think physicians are starting to get their power back and get their voice back. And for me, private practice has been freeing in that capacity because it allowed me to really get my hands in on the patient experience and change things as much as I could to optimize that patient experience.
Well, I think you've done a fantastic job.
Thank you.
I'm so grateful for you.
Thank you.
For everything you've done for me in my life. And I just hope that this episode reaches somebody else who might want to reach out, because you've changed me.
Stop.
So thank you for coming on. I really, really appreciate you and everything that you do. And you are changing the game. And I hope that other people follow suit.
Oh, it's my absolute deepest pleasure. I find so much meaning in my work. And I always say it's a two-way street. I feel like my patients find me, right? Like I find these beautiful friendships. Sure. Yeah. They choose me for a reason, and I am blessed, and my fate has allowed me to work with them for a reason. And we get to form these beautiful friendships. And I think that is why I get to enjoy my job as much as I do.
I love it.
So thank you for having me.
Yay! I only cried at the end.